Hi, welcome to our EBR project, Transcutaneous Electrical Nerve Stimulation, also known as TENS. This is Billy Brown. I'll be narrating part of the presentation along with Rebecca Alvarez, Valerie Canales, and Blake Carter.
This is the strength duration curve, which shows the different nerve fibers that can be stimulated at different pulse durations for differing physiological effects. As you can see, for TENS, the goal is to stimulate A beta nerve fibers to achieve pain relief, which can be accomplished with a pulse duration of 50 to 80 microseconds. When the A beta nerve fibers are stimulated, pain signals are blocked, which is the goal with using a TENS unit. This can help control and relieve pain in musculoskeletal conditions as an alternative to pain medication. This can also enable patients to play a more active role in their treatment by allowing them to exercise and perform activities of daily life that they were once unable to perform due to the pain that they experience. There are certain pre-existing conditions that would contradict the use of a TENS unit and be unsafe for patients. These conditions include pacemakers and heart conditions such as unstable arrhythmias, if the electrodes would need to be placed over the carotid sinus, any venous or arterial thrombosis or thrombophlebitis, and lastly for women, pregnancy, especially during the first trimester.
Treatment parameters include frequency, pulse duration, amplitude, and placement. The frequency for TENS is 100 to 150 hertz. The pulse duration is between 50 to 80 microseconds. Duration of this treatment should be about 20 to 30 minutes in the clinic, or it can be used as needed outside of the clinic. It's safe to use up to 24 hours. Amplitude should be strong but comfortable tingling sensation. It should never feel uncomfortable or painful. Placement of the electrodes are between 2 and 4 and can be placed in a bracket, parallel, unilateral, or crisscross format. The electrode should be at least one electrode width apart or 2 inches. Physiological effects of TENS. Once the modality is applied, there should be immediate pain relief. Once the treatment ceases, pain will come back. Pain relief is established through the gate control theory. The gate control theory is the stimulation of A beta fibers that inhibit the transmission of pain to the brain.
To use or not to use TENS, this is really the question that we need to ask ourselves as physical therapists and as practitioners when it's going to be appropriate to implement a TENS, whether continuous or acupuncture-like TENS treatment on a patient, and how it will benefit their functional outcome. The paper that we chose to review was the use of TENS for functional improvement. What is functional improvement? Well, it's up to the patient. It's whatever they deem appropriate in their life that they want to have overall improvement or increased ability to do. Now, with our paper, the TENS was for relief of chronic low back pain with or without radicular pain, simply nerve pain, and it was published in the 2012 European Journal of Pain. The primary objective of the study was to evaluate the efficacy of TENS on a functional status, starting at baseline, going again at 6 weeks, and then tested finally at a 2-year period. The main rubric they used for this test was the Rowland-Morris Disability Questionnaire, also known as the RDQ, and men and women were both enrolled, varying in age from 36 to 63. Finally, this was a single randomized controlled trial that used both active TENS on 117 patients and sham TENS on 119 patients. Now, these TENS units modulate a little bit different than just a strict conventional or a strict acupuncture-like TENS. They modulated between both conventional TENS at 80 Hz and then acupuncture-like TENS at 2 Hz every 3 seconds to prevent pain accommodation. This just shows a brief overview of the procedure that was used in the study. Again, it was modulated TENS, varying from conventional to acupuncture-like TENS during the day. Devices were required to be used for 1 hour treatment time 4 times a day, and this went on for 3 months. Both devices had auto recorders. This ensured compliance both in the active TENS group and the sham TENS group, which the sham treatment did not administer any type of electrical stimulation. Chronic low back pain without radicular pain, there was just 2 electrodes used, and with radicular pain there was actually 4 electrodes used, 2 over the painful area and then 2 more electrodes over the nerve involved in radiculopathy. Here are 2 pictures showing the electrode placement for the research study. The picture on the left shows the 2 pads that were placed over the site of low back pain at the source of the pain without radiculopathy, and the picture on the right shows 2 pads over the site of low back pain and then 2 more pads over the site of radiculopathy. Following are the most notable outcomes from the actual study, and interestingly, the rest of the outcomes either had no benefit or actually added pain to the treatment group. Now, while 30% improvement in functional status looks pretty good for the treatment group versus the sham group, when you look at the sham improvement, it's actually at 25. So it kind of leads you to believe that maybe the patients having the machine on them alone actually led to a functional improvement. I think a special note is that medication use within this patient population didn't actually decrease, and that's pretty concerning for the efficacy of the use of TENS when our goal is to decrease pain so that we don't have to use things such as medication or pain blockers. While this was a very well written and well conducted randomized controlled trial, there are some weaknesses to the actual study itself. One of those being no exercise or prescribed therapy, which is pretty important. As the physical therapist, we need to know what types of therapy interventions can be used in conjunction with TENS to improve a functional outcome. Also, there wasn't really much variety with the younger population of patients. Most of the patients were either middle-aged, getting on to older age in their early 60s, and there wasn't a relationship between TENS use in younger patients, such as athletes who are recovering from a surgery and need a catalyzing boost to get back into the treatment program. Since this article only used TENS and not another therapeutic intervention, what are some of the conclusions that we can draw, and how is it going to change our practice as physical therapists? Well, the main takeaway is that active TENS doesn't really have a marked impact on improvement of function when it's used as a standalone treatment. And this can be pretty empowering for some patients that come in, state that they only want the machine's going to make them better, and this is the only way they're going to improve, when you can actually show them, hey, there's other people just like you out there who thought the same thing, they came in, they got the treatment, and this is what happened. This is pretty empowering for patient perception. And also, we know that TENS is good for use, actually great for use during exercise, but should we still use it as a catalyst to initiate movement when that patient's pretty motivated to get going and get after it in their own treatment plan? Also, long-term use of TENS doesn't show any benefit in improving overall functional outcomes. So if you have that patient, the only way you can get them up and exercising is on the TENS unit, maybe you should start thinking of some other ways that you can incorporate other pain blocking mechanisms or other activities that will distract that patient from the pain so they don't become dependent on the actual TENS unit.
So how should we use the conclusions from this study to treat future patients? Basically, this article was just another great example that modalities such as TENS should not be used as a sole treatment, but part of a bigger plan for the patient. We've seen throughout this quarter that a lot of modalities that we went over do not have a lot of research backing them, but when used as part of a multidisciplinary treatment approach, the effects can be augmented. Since decreases in low back pain were observed in the active TENS group, we could say for future patients that we could use TENS just to mask that pain, while we use other modalities such as exercise and manual therapy that have shown to improve functional outcomes to help that patient. We should also remember that each patient is different. I think this is highly patient specific. If a patient just enjoys TENS or heat or ice or whatever it may be, we can use that as a placebo effect, and then, like I said earlier, use other modalities that will truly help the patient. Unless the patient is highly irritable or requiring rapport, we just need to be cautious when we use a modality such as TENS because it can take away from that patient therapist time that can be spent more efficiently. We need to focus on educating the patient and supplying them with a home exercise program if possible, and other physical aids or modalities that can help them at the same time. And this has been our project. I hope you enjoy, and if you have any questions, just comment below. Thank you.